Hello, this is a video lesson on the procedures of the shoulder girdle. So to start off by talking about how we need to prep the room and have it ready for the patient before coming in, and then as well as prep the patient to make sure that we have no artifacts on the images. The image receptor and the collimation size are important that we adhere to that. We'll talk about those requirements. Our SID for most of these procedures is going to be 40 inches with one exception. The one exception are AC joints, that's going to be 72-inch distance. We're going to use the correct ID markers. We're going to shield our patient for all these procedures, and then we're going to provide the appropriate patient instructions. So to start off with projections of the shoulder, we have 3 AP projections. And the AP projections, we're just going to have the patient stand as though they're the anterior to posterior, but we're going to either externally, internally, or neutrally position the arm. So we also have the AP oblique projection Gracie method. We're going to talk about the transthoracic lateral projection, which is called the Lawrence method. The inferior superior axial projection called the Lawrence method as well. The PA oblique projection, which is the scapular Y, and then end with the tangential projection called the Near method. So let's begin with the AP projection of the shoulder. So for the 3 AP projections of the shoulder, we're going to have the patient upright if possible or supine. We want to make sure the coronal plane of the thorax is going to be parallel to the image receptor. We want to center the shoulder joint to the midline of the grid, and we're going to center 1 inch inferior to the coracoid process. We're going to suspend respiration, the central way I already mentioned, so we won't repeat that again. We're going to have this 10 by 12 lengthwise or crosswise depending upon department protocol. If it's crosswise, you want to include 1.5 inches above the shoulder, 1 inch beyond the lateral aspect of the shoulder, the sternal into the clavicle, and the proximal third of the humerus. If it's lengthwise, then more of the humerus and less of the clavicle will be included. The structures shown are going to be the bony and the soft tissue structures of the shoulder and the proximal humerus in the anatomic position. We're going to see the scapulohumeral joint relationship that is visualized, and we're going to see specific structures for the external, the neutral, and the internal rotations, which is what we're going to talk about next. So for the external rotation, which is our very first one, we're going to have our patient supinate their hand. The epicondyles, therefore, will be parallel to the plane of the image receptor. This is a true anatomic position. And the images that you can see here, we're going to see the greater tubercle in profile. The epicondyles are going to be parallel to the image receptor, and the greater tubercle is in profile. And so that's what we're looking at here, is that the humeral head's in profile, the greater tubercle's in profile on the lateral aspect of the humerus. The scapulohumeral joint is visualized with slight overlap of the humeral head on the glenoid cavity, which is shown, and the outer line of the lesser tubercle is visualized. For the neutral rotation, we're going to have the patient put their palm of their hand against their hip. This is the other alternative is for the patient to hold their arm. This case for neutral is for trauma. That's the reason why we're doing neutral rotation, is for trauma. The epicondyles are adjusted at approximately 45 degrees with the plane of the image receptor. We're not going to do that to our patient. That naturally occurs if your patient is in a neutral rotation. And we're going to see the greater tubercle is going to overlie the humeral head. So we're looking at the neutral rotation. We're going to see the two greater tubercles partially superimposing the humeral head. Humeral head is in partial profile, and there's slight overlap of the humeral head on the glenoid cavity. The final one is the internal rotation, which is a lot like a lateral projection of the humerus, except that we're going to put the arms straight down by their side. In this case, their epicondyles are adjusted perpendicular to the image receptor, and the posterior aspect of the hand is on the image receptor. So in addition to that, we're going to see that the lesser tubercle is in profile, and that it is overlapping the scapula, but it is in profile. And so in addition to that, the outline of the greater tubercle superimposes the humeral head, and the greater amount of the humeral overlap of the glenoid cavity than in either the external or the neutral positions. We're going to take a look at the AP oblique projection Gracie method. So this can be performed upright or supine. We're looking at this being with centering the image receptor to the scapulohumeral joint, which is 2 inches medially and 2 inches inferior to the superior lateral border of the shoulder. We're going to rotate the patient 35 to 45 degrees toward the affected side. Remember that this patient currently is in an RPO position, so his affected side is the right side. Now, if he's recumbent, we're going to perform this with a rotation of 45 to 60 degrees instead. We're going to abduct the arm slightly internally and place the palm of the hand on the abdomen. We're going to suspend breathing, and we're talking about the central ray being perpendicular to the image receptor. The central ray should be a point 2 inches medially and 2 inches inferior to the superior lateral border of the shoulder. The collimation is an 8 by 10. So when we're talking about this, there's specifics about the lengthwise and crosswise is about like exactly which is how to position. Structure shown is the joint space between the humeral head and the glenoid cavity is very important. That's the whole point of this projection. And that's exactly what is visualized. We're looking here at that glenoid cavity, that joint space between the glenoid cavity and the humeral head. So the glenoid cavity is in profile. The transthoracic lateral projection Lawrence method is taken through the thorax. So the affected side, and this purpose is for trauma. Very important also, just like the neutral position rotation was for trauma, this is for trauma as well. So this could be performed with a patient upright or in a dorsal decubitus position. You want to have them raise their unaffected arm, and their bad arm or affected arm should be next to the image receptor. When the mid-coronal plane is perpendicular to the image receptor, and we're not going to attempt to move or rotate the injured arm at all. We're going to center the image receptor to the surgical neck of the affected humerus. There are two respiratory options that we have. The first one is full inspiration, and the second one is a breathing technique to blur the pulmonary vasculature. The purpose of the full inspiration is to improve contrast. So we're going to enter the mid-coronal plane of the body at the level of the surgical neck. If the patient cannot elevate the unaffected shoulder, you can angle the central ray 10 to 15 degrees cephalad. You're going to open up your light field at 10 by 12 inches lengthwise, and you're going to get a lateral projection of the shoulder and the proximal humerus projected through the thorax, which is why it's called transthoracic, through the thorax. And that's what you're doing. You want to be able to see the entire humeral head. You can see the scapula, the clavicle can be visualized as well. And we're looking at the unaffected clavicle and humerus projected above the shoulder closest to the image receptor. But the goal is to see the humerus and the proximal humerus. The shoulder inferior superior axial projection Lawrence method is one in which we're going to have the patient recumbent. They're going to be in a supine position, elevate their head, the shoulders, and the elbow approximately 3 inches. They'll abduct the arm of the affected side at a right angle to the long axis of the body, and you're going to keep the humerus in external rotation. Adjust the forearm and hand in a comfortable position, and you're going to have the patient turn their head away from the side being examined so that the image receptor can be placed against their neck. You're going to place the image receptor on the edge against the shoulder as close as possible to the neck, and then we're going to use a vertical holder if we can, so we don't have to have the patient hold the image receptor. We're going to suspend respiration, and we're going to go horizontally through the axilla to the region of the AC joint, and we're going to angle 15 to 30 degrees medial to the shoulder and the image receptor. We're going to have their central ray is going to be 12 inches in length and 1 inch above the anterior shadow of the shoulder. So the goal is to see an inferior superior axial projection of the proximal humerus, the scapulohumeral joint, lateral projection of the coracoid process, and the AC articulation. There's also the insertion side of the subscapular tendon can be seen on the lateral lesser tubercle of the humerus. In the image shown, we're going to be looking for the scapulohumeral joint with slight overlap. We're looking for the coracoid process that is facing anteriorly, and we're looking at the lesser tubercle in profile and directed anteriorly. The next is the shoulder, looking at the P oblique projection scapular Y. We're looking here at the purpose being shoulder dislocation. Now, it's preferred to perform this upright, and if we do so, it's recommended that we do an RAO or LAO. However, if the patient is severely injured and recumbent, we could perform an RPO or LPO. So we want to rotate the patient so the mid-coronal plane forms an angle of 45 to 60 degrees, and that's because that is the angle that the scapula lies at, again, in the body. So the PA oblique, we're going to rotate the body with the affected side closest to the image receptor. So in the example up here at letter A, we're looking at the patient being in an RAO, so we're looking at his right scapula. In the AP oblique projection, we would be looking at the side away from the image receptor, so we would have a lot of OID. So you want to make sure that the flat surface of the scapula is perpendicular to the image receptor, and you want to center to the image receptor to the level of the scapulohumeral joint. You want to suspend respiration, and you perpendicular to the scapulohumeral joint again. The collimation should be 12 inches in length and 1 inch beyond the lateral shadow. We're going to see a scapular Y that's shown with an oblique image of the shoulder. And so in a normal shoulder, the humeral head is superimposed over the junction of the Y. So taking a look at this is that the body of the scapula forms the vertical part of the Y, and that overlaps with the humerus. We're going to have the humerus superimposed over that. The chromion forms the top part of one part of the Y, and then the coracoid forms the anterior part. So we've got the upper part of the Y, which is the acromion and the coracoid, and the lower part, which is the humerus and the scapula. Normally, the humeral head will sit right in the center, right within the top part of the Y. So it'd be superimposed. If there's an anterior dislocation, then the humeral head would be seen beneath the coracoid process because the coracoid is located anteriorly. And if there's a posterior dislocation, it would be seen beneath the acromion because the acromion is posterior in position in relation to the body. So here's an example of a scapular Y normally, and on the right hand side is where the humeral head is under the coracoid process. So that's where an anterior dislocation. And then we have the scapular Y looking at the evaluation criteria. So we want the humeral head and the glenoid cavity superimposed. The humeral shaft and the scapular body should be superimposed. So we should not have the arm should be just straight down by the side. There's no superimposition of the scapular body over the bony thorax. The acromion is projected laterally and free of superimposition, and the coracoid is possibly projected below the clavicle. So here's the acromion, and there's the coracoid. The scapula should be in lateral profile with the humerus overlapping. So the two should be overlapping, and so that's why we get the true Y, or how we get the true Y. So I want to show this because in the scapular Y, we have a 45 to 60 degree oblique, just like we do with the near method, which is coming up in just a moment, and the lateral projection of the scapula. In all cases, the scapula is perpendicular to the image receptor. In the central ray location angles, the near method is we have a 10 to 15 degree caudate angulation, but the scapular Y and the lateral scapula, we do not have angle perpendicular to the image receptor, so no degree angulation. The central ray angulation entrance point is the superior humeral border for the near method, the scapulohumeral joint for the scapular Y, and the center being at the medial border of the scapula for the lateral scapula. And for the scapular Y, we want the arm position at the side like it was mentioned. As well as even with the near method, should be the same position. It can vary for the lateral scapula, and we'll talk about that later on. So here's the tangential projection of the shoulder. It's called the near method, otherwise called a supraspinatus outlet. And so what we're doing is we're tangentially trying to show the coracoacromial outlet, and we're trying to diagnose shoulder impingement in this case. So patients either in an RAO or LAO, just like they were for the scapular Y. The only difference between this and the scapular Y is that we're going to angle the tube 10 to 15 degrees caudad, and we're also going to enter a different location. We're going to enter the superior aspect of the humeral head, which is what makes this a tangential projection. So this is going to show the posterior surface of the coracoacromion and the AC joint identified as the superior border of the coracoacromial outlet. And so that is the point, is that we wanted to see this outlet to look for shoulder impingement. AC joints. The AC joints are taken with only AP projections bilaterally with and without weights, and it is called the Pearson method. So we're going to perform this at 72-inch distance. The patient has going to be upright for this one, seated or standing. To adjust the height of the image receptors to the midpoints at the same level as the AC joints. We're going to center the midline of the body to the midline of the grid, and we're going to ensure that the body weight is equally distributed to avoid rotation. We're going to have the patient's arms hanging by their sides, adjust the shoulders to lie in the same horizontal plane, and it is important that the arms hang unsupported. We take 2 exposures. One is without weights, and the second is with equal weights, 5 to 10 pounds affixed to each wrist. And instruct the patient not to favor or tense up the injured shoulder. We want to perform this on suspension, and we want to be perpendicular to the midline of the body at the level of the AC joints for a single projection, and to at the center, when both of them are, 2 are needed, we're going to center the respective AC joint. We're going to collimate 6 by 17 if we're including both joints on a single exposure, or 6 by 8 for separate exposures. And the goal is to have bilateral projections, bilateral images of the AC joints, where we have the bilateral images with and then bilateral images without weights. And so here's an example of where the images were taken with weights on the top image, and the bottom one was taken without weights. And in both projections, the collimation was performed to collimate down to where we're at this, basically in the center between the 2 clavicles. The clavicle is performed either AP or PA, or can be performed with an AP axial or PA axial. If you're doing upright, it's recommended to do the PA and the PA axial to decrease OID. But of course, if your patient is, or your routine is different, then you can perform it AP and AP axial. But the patient is also in trauma, or they have an injury, then you'd want to keep them recumbent. So in the AP or the PA projection, you want them upright or recumbent. You want them, adjust the body for the clavicle to the midline of the image receptor, and the arms should be along the sides of the body, and the shoulders to lie in the same horizontal plane. You want the clavicle to center your clavicle to the image receptor, and you're going to suspend respiration at the end of expiration. We're going to center perpendicular to the midshaft of the clavicle, and we're going to collimate down to an 8 by 12. We want to see an AP or PA projection of the entire clavicle. And so the goal is to get the entire clavicle centered on the image, the lateral half of the clavicle above the scapula, with the medial half superimposing the thorax. And that's pretty normal. So we're going to have superimposing at least half of that clavicle. On the AP or the AP axial clavicle, you could technically use lordotic position where you would angle 0 to 15 degrees, or you could have the patient standing upright or supine with a 15 to 30 degree angulation instead. We're going to suspend at the end of full inspiration this time so we can elevate the clavicle further. So we went to center to the mid shaft, and we went to the collimation to be an 8 by 12. You want to go with have at least 1.5 inches above the shoulder and 1 inch beyond the 1 inch beyond the lateral border of the shoulder, the entire clavicle. The goal is to get an axial projection of the clavicle projected above the ribs. So we want evidence of proper collimation and presence of the side marker placed clear of the anatomy. We want the entire joint along with the AC joint and SC joints on the image. So here's the SC joint and here's the AC joint. So we want to see both of those. In the axial projection, we're going to see that there's 2/3 of the clavicle projected above the ribs and the scapula, and the clavicle is in a more horizontal orientation. And now we have the scapula. The scapula, we have an AP projection and a lateral projection to perform. The scapula is shown here with the coracoid process shown anteriorly, and then we've got the acromion shown more posteriorly, as well as the glenoid cavity shown as well. So the AP projection, we're going to perform upright or supine. We're going to have it so that they adjust the patient's body and center the affected scapula to the midline of the grid. Adjust the arm to the right angle of the body to draw the scapula laterally. Flex the elbow and support the hand in a comfortable position. So it's kind of like a stop sign position, or that you could put your patient's arm in. But the arm is in a comfortable position. They should be at a right angle. Is what we're looking at. You're going to position this patient with about you want to have the essential ray about 2 inches inferior to the coracoid process, and you're going to use slow breathing to blur the ribs. You're going to use a 10 by 12, and you can do 1.5 inches above the shoulder, 2 inches beyond the lateral aspect of the shoulder, and the lateral half of the clavicle shown, as well as 1 inch below the inferior angle of the scapula. But we want to see an AP projection of the scapula. So the reason why we perform abduct the arm is to pull the scapula away from the ribs, to pull it out as much as possible. So try to get that free superimposition from the ribs as much as possible. The scapula should be horizontal, not slanted, and we should see the acromion and we should see the inferior angle as well. The lateral projection has 3 different methods for how to position. It can be upright or prone, and it should be performed with an RAO or LAO if at all possible. We're going to oblique the patient 45 to 60 degrees as far as the rotation, and we're going to have the acromion and the coracoid. If we want to visualize those, we want to flex the elbow and place the hand on the posterior thorax as shown in the image on the right. So we want to position it that way. If we were positioning the body, we want to extend the arm upward and rest it across the form on the head, or bring it across the upper anterior chest and grasp the opposite shoulder. I'll show that on the next couple slides. We want to perform this on suspension, suspend breathing, and we want to be perpendicular to the mid-medial border of the protruding scapula. And we're going to do a 10 by 12 again, include 1.5 inches of the shoulder and 1 inch beyond the lateral shadow. We're going to do a lateral projection of the lateral image of the scapula, and placement of the arm determines the position of the superior scapula to superimpose over the humerus. So starting off with looking at the what the evaluation criteria is we want to see the lateral and the medial borders of the scapula, which they should be superimposed. The humerus should be out of the way, which it is. It should not be superimposed. And we should see the acromion, and as well and the since that's the highest point, as well as the inferior angle. So if we want to see the acromion and the coracoid in profile, then we're going to want to have the position the arm on the posterior chest for this lateral projection. If we're wanting to see the body of the scapula, then you'd prefer to put the arm across the upper anterior thorax and grasp the opposite shoulder, and that would give you the best view here. Another option is that you want to see the body of the scapula is to extend the arm up across over the head, and that's an option you have as well. And here's the three options. Here's the arm of the posterior thorax where we see the acromion and the coracoid. We can see the arm across the upper thorax where we see the body of the scapula, or we can have the arm extended above the head, which is going to be showing the body of the scapula as well. And this concludes our lesson on the shoulder girdle. Thank you.